and HOD, Department of Anesthesiology, Mysore, Educational Qualifications, MD from MMC, 35 national and international publications, Treasurer of ISA Mysore branch in 2012, Examiner for MD and DA examinations, non-academic achievements, many awards in yoga and spiritual activities, guest lectures in yoga and spiritual development, present Mysore City branch ISA President. Over to you, sir. Thank you.
Jai Guru, good morning everyone. The topic allotted to me is a parturient with Hellp syndrome posted for emergency cesarean section. I will be discussing this under the following headings: history of Hellp syndrome, incidence of Hellp syndrome, etiology for Hellp syndrome, pathophysiology of Hellp syndrome, how to what are the signs and symptoms of Hellp syndrome, investigations required to diagnose Hellp syndrome, differential diagnosis of Hellp syndrome, medical management of Hellp syndrome, then anesthetic management of Hellp syndrome and complications. The acronym Hellp was coined by Weinstein in 1982 to describe a syndrome consisting of hemolysis, elevated liver enzymes, low platelet count. Hellp syndrome is a variant of preeclampsia. They occur usually in third trimester or after childbirth. Hellp syndrome may be a variant of severe preeclampsia, but this is controversial because substantial fraction of Hellp syndrome do not have hypertension or proteinuria. 70% of Hellp syndrome patients deliver preterm. Prematurity complications increase the risk of perinatal mortality and morbidity. Coming to incidence of Hellp syndrome, it is about 2 to 12% of all pregnancies. If you count it in preeclampsia, it is about 10 to 20%. It occurs 70% during antepartum, occurs 30% during postpartum, usually occurs in the first 48 hours. Coming to etiology for Hellp syndrome. The etiology for Hellp syndrome is searching for a black cat in a dark room. That means idiopathic. The exact etiology is still not known. That is the etiology for this Hellp syndrome. Other proposed theories are placental insufficiency, genetic and hormonal factors, endothelial dysfunction, oxidative stress, immune system response, blood vessel function constriction and dilatation defects. What are all the diagnostic criteria for Hellp syndrome? Hemolysis, elevated liver enzymes and thrombocytopenia. These are the three criteria. Among the hemolysis, abnormal peripheral blood smear, increased bilirubin level more than 1.2 milligram per deciliter, increased LDH level more than 600 international units per liter, elevated liver enzymes, AST more than or equal to 70 international units per liter, increased LDH more than 600 international units per liter, platelet count less than 1 lakh. Coming to classification of Hellp syndrome, it can be classified in two ways. It is partial and complete. Partial, where one or two abnormalities will be there. Incomplete, all the three abnormalities, as I told, all the three abnormalities will be there. Another way of classifying, class 1, class 2, class 3. It is based on the platelet count. Less than 50,000, class 1. In class 2, 50,000 to 1 lakh. In class 3, more than 1 lakh platelet count. More severe form is class 1. Coming to pathophysiology of Hellp syndrome. It is a syndrome that is characterized by hepatic endothelial disruption followed by platelet activation, aggregation and consumption, leading to ischemia and hepatocyte death. Etiology for elevated liver enzymes thought to be secondary to fibrin deposits in sinusoids causing blood flow obstruction. Obstruction to hepatic blood flow in turn results in periportal necrosis, hepatic hemorrhage, subcapsular hematoma. Hemolysis is due to microangiopathic hemolytic anemia. Red cells fragmented when they pass through microvascular vasculature with endothelial damage and fibrin deposits. Results in increase in bilirubin and LDH levels. Peripheral blood smear demonstrates Burr cells, echinocytes and schizocytes. Decreased platelet count is due to increased consumption of platelets. Platelets are activated and adhere to damaged vascular endothelial cells, resulting in increased platelet turnover with shorter lifespan. Coming to clinical feature, these symptoms usually present with nausea, vomiting, headache, right upper quadrant pain, epigastric pain, visual disturbance, and malaise. Signs are hypertension, pedal edema, tenderness in the right upper quadrant, and pallor. Differential diagnosis for the Hellp syndrome are acute fatty liver of pregnancy, cholestasis of pregnancy, gastroenteritis, glomerulonephritis. These are all the differential diagnosis for Hellp syndrome. This is this one retrospective study conducted on 442 patients. The commonest complication found was disseminated intravascular coagulation, which was found 21%. Then followed by placenta abruption 16%, acute renal failure 8%, severe ascites 8%, pulmonary edema 6%, pleural effusion 6%, other complications less than almost less or equivalent to 1%. Rupture of subcapsular hematoma of the liver. It is a life-threatening complication, usually present with abdominal pain, nausea and vomiting, headaches, pain localized to the epigastric area or right upper quadrant, hypotension and shock typically develop and the liver is enlarged and tender. Diagnostic criteria for Hellp varies. Usually LDH more than 600 international units per liter, AST more than 70 international units per liter, platelets less than 1 lakh per cubic millimeter, urine there will be proteinuria, hepatoglobin level will be increased, fibrinogen degradation predicts more than 40 milligram per deciliter, fibrinogen degradation predicts in DIC less than 40 milligram per deciliter, thromboelastography to know the etiology of bleeding, and can order for this one platelet function analyzer, unread, or TEG or ROTEM. Also you can order ultrasonography, computerized tomography, MRI of liver. Next, coming to management of this Hellp syndrome. The first priority is to stabilize the maternal condition with particular attention given to hypertension and coagulation abnormalities. Next, the fetal condition should be assessed with fetal heart rate monitoring, Doppler ultrasonography of fetal vessels, a biophysical profile, or several of these options. Some of the drugs used in this syndrome are corticosteroids, antihypertensive drugs, and magnesium sulfate. Plan of our management should be the ultimate treatment of for this Hellp syndrome is the delivery of the fetus and removal of the placenta. That should be our goal. Delivery in 48 hours after evaluating or stabilizing maternal clinical conditions and treating with corticosteroids, the most advisable option appears to be 27 to 34 weeks of gestation. Wait and see attitude in pregnancy earlier than 27 weeks and treatment with corticosteroids, corticoids. Corticosteroids, why they are used? For the fetal lung maturation, usually betamethasone is used. For maternity benefits, suppose if the patient is in severe complications, then also we can use higher dose of corticosteroids, especially with the patient with lower level of platelets, extremely high level of liver enzymes, or diminished urine output. You can use corticosteroids for maternal benefit. The antihypertensives commonly used are the labetalol is the drug of choice. Our aim is to lower the systolic blood pressure to 140 to 150 millimeters of mercury and diastolic blood pressure 90 to 100 millimeters of mercury. Other drugs used are hydralazine, methyl dopa, nifedipine, and others. The main anticonvulsant used is magnesium sulfate is the drug of choice for prophylaxis, treatment, and recurrences. Already Madam told. The antidote for magnesium toxicity is 10% calcium gluconate, 1 gram administered over 10 minutes. Platelet transfusions are indicated in the presence of significant bleeding and in all parturients with platelet count less than 20,000 per cubic millimeter. For women with platelet count less than 40,000 per cubic millimeter who are scheduled for cesarean delivery, the pre-incision administration of 6 to 10 units of pooled random donor platelets or 1 to 2 units of apheresis platelets. At least 2 red blood cells units should be typed and cross-matched and large bowel intravenous access obtained. If DIC occurs, it can be treated with fresh frozen plasma to replace clotting factors. What are the indications for plasma pheresis? In patients who are refractory to conventional medical treatment, removes plasmal factors and replaces new elements by encouraging plasma from patients, For bilirubin or creatinine has progressively increased for more than 72 hours after delivery. These are the indications for plasmapheresis. What are the indications for fluid therapy? You have to use judicially this fluid. Restrictive therapy. What are these complications of restrictive? It may exacerbate intravascular vasoconstrictors, lead to kidney failure. Non-restrictive therapy. What are they? These one complications. Positive fluid balance entails a possible risk of producing pulmonary edema. Use of intravenous fluid to increase plasma volume or to treat oliguria in women with normal renal function and stable creatinine levels is not advisable. Nor is treating oliguria with furosemide and low doses of dopamine recommended in women with normal renal function. Now the patient is posted for emergency cesarean section. What should be our goal? Preoperatively, you will assess the patient. You have to take the IV line. You have to monitor this one blood sugar, catheterize, cross match this one blood, and also keep ready that blood products. Then clinical situation, depending upon this one clinical, if the patient has got raised intracranial pressure and there is a clinical evidence of bleeding, coagulopathy, drop in platelet count less than 80,000 per cubic millimeter, if there is hemodynamic stability, and if there is this one maternal or fetal compromise, then you go for general anesthesia. If there are no this one raised intracranial, then you go for regional anesthesia. These are the advantages and these are the disadvantages. The advantages are rapid onset of anesthesia, control of general advantages of general anesthesia are rapid onset of anesthesia, control of airway, potential for less hypertension than regional anesthesia. Regional advantages are avoiding this one polypharmacy, reduces the serum catecholamine level, improves the uteroplacental fluid flow, precludes the risk of aspiration, failed intubation or laryngoscopic intubation, minimizes the risk of neonatal exposure to depressant anesthetic drugs. What are the investigations you want to order in these patients? ECG, a complete blood count with platelet count, LFT, RFT, FDP, PT and APTT. Blood products. Blood components include cross-matched red cells, platelet concentrates, plasma should be available. In thrombocytopenia, platelet transfusion should be considered at the time of surgery and not before platelets can be rapidly consumed. You have to catheterize the patient. What are the anesthesia techniques available in a patient posted for this emergency, regional or general anesthesia? What are the indications for CVP? The indications for CVP are oliguria, resistance to fluid therapy, pulmonary edema, some form of heart disease, refractory hypertension. Transthoracic echocardiography can be used in a place of invasive monitoring to quantify cardiac function and also volume status. Neuraxial anesthesia for labor. Recommended for several reasons because it avoids GA and possibility of airway catastrophe and marked hypertension with laryngoscopy in the event of emergency cesarean delivery, optimize timing of epidural catheter placement in a setting of declining platelet count, and obtain the beneficial effects of neuraxial analgesia on uteroplacental perfusion. Advantages of lumbar epidural analgesia are provision of high quality analgesia which attenuate the hypertensive response to pain, a reduction in levels of circulating catecholamines and stress-related hormones, possible improvement in the intervillous blood flow, and provision of a means for administration of local anesthesia for emergency cesarean delivery, thus obviating the need for general anesthesia. However, 4 special considerations exist in preeclamptic women. Number 1, assessment of coagulation status. Number 2, intravenous hydration before the epidural administration of local anesthetic, treatment of hypotension, and as far as possible, you avoid the use of epinephrine containing local anesthetics. Assessment of coagulation status, whether the patient has got platelet count more than 1 lakh, 50 to 1 lakh or less than 1 lakh, you order for PFA, platelet function, analyze 100 or 200, TEG or ROTEM. Precautions to be taken. Anesthesia to be administered by a skilled anesthetist. Spinal technique may be preferable to an epidural technique. Use of flexible wire embedded epidural catheter. The patient should be carefully monitored after delivery for neurological sign. The platelet count should be checked for evidence of return to normal measurements at least 75,000 to 80,000 before removal of the epidural catheter. Imaging studies and neurological or neurosurgical consultation should be obtained immediately if there is any question of epidural hematoma. Removal of epidural catheter. If there are no signs of intraspinal bleeding, the catheter must be removed as soon as possible, given the risk of intravascular catheter migration and bleeding could begin. If bleeding is observed around the insertion point, it could also occur in the intraspinal or epidural space, so the catheter must be left without moving it. General anesthesia. It involves a higher maternal-fetal anesthetic risk. The indications for general anesthesia are severe ongoing maternal hemorrhage, sustained fetal bradycardia with reassuring maternal airway examination, and severe thrombocytopenia or other coagulopathy, pulmonary edema, and if the level of consciousness is altered. These challenges in general anesthesia are the potential difficulty of securing the airway, the hypertensive response to direct laryngoscopy and tracheal intubation, the effects of magnesium sulfate on neuromuscular transmission and uterine tone. The other challenges are coagulation and bleeding abnormalities, liver dysfunction, hemodynamic instability, airway management, fluid management, seizure risk, multi-organ involvement, pre-existing conditions, patient positioning and neonatal considerations. These are the anesthetic challenges. Airway considerations in patients with Hellp syndrome. Indications for invasive blood pressure monitoring. Invasive blood pressure monitoring should be initiated before the induction of general anesthesia in patients. Endotracheal tubes in various sizes and difficult to wear equipment should be immediately available. Patient in the supine position with left uterine displacement and denaturation to help the ensure optimal maternal oxygen. Rapid sequence induction and intubation. Avoid repeated intubations. Proceed with insertion of supraglottic airway devices before the airway is irretrievably lost. Obstetrician should be encouraged to complete the procedure as quickly as possible. Hemodynamic monitoring. Indications for this one, hemodynamic monitoring, invasive monitoring. Poorly controlled maternal blood pressure, need for frequent arterial blood gas measurements, especially in the context of pulmonary edema, planned use of rapid acting vasodilators, use of calculated systolic pressure variation to estimate intravascular volume status, need for continuous blood pressure monitoring during the induction of and emergence from general anesthesia in hypertensive women with severe preeclampsia. Hypertensive response. Risk of cerebral hemorrhage or pulmonary edema is more. To attenuate intubation response, hypertensive, we use this one, labetalol and other drugs. The goal of this one should be to bring the blood pressure to systolic pressure to 140, diastolic pressure to 90, maintain systolic blood pressure between 140 to 60, diastolic pressure 90 to 100. Effect of magnesium sulfate, already madam discussed this one. Postoperative analgesia, same as for healthy pregnancy. If the postpartum hypertension persists longer than 1 day, the SCOG has suggested non-steroidal anti-inflammatory medications to be replaced by alternative analgesics. In case of continuous severe refractory hypertension, continuous epidural analgesia for its blood pressure and modulating properties. Postoperative management. In most patient blood pressure, platelet count and levels of liver enzymes normalize within 48 to 96 hours, but pulmonary edema is also highest in the postpartum period. Sustained hypertension, stroke, venous thromboembolism, airway obstruction, and seizures. Eclampsia can present for the first time in the postpartum period with delayed presentation as late as 4 weeks after delivery. ACOG recommends antihypertensive therapy in the postoperative period when the systolic blood pressure persistently exceeds 150 millimeters of mercury or diastolic blood pressure more than 100 millimeters of mercury, who develop new onset of hypertension associated with headaches or other neurological symptoms. The main induction agents used in Hellp syndrome are propofol. We have to use targeted infusion technique. Opioids used are remifentanil and muscle relaxant rocuronium. You have to reverse the patient using the myopyrolate. Thank you.